to this session of Aishala. So we'll be going through the basics of a number of basic investigations in retinal sciences, and I hope this will really benefit all our postgraduates and fellows who are here. So without further ado, it's my pleasure to invite Dr. Unnikrishnan Nair to speak on interpretation of OCTA. Over to you, Unni.
Okay. Thank you. Do we have any postgraduates or one? So this is entirely dedicated to you now, sir. Slides are not moving. Okay. So just to start a few slides on what we mean by OCTA, we're just talking about repetitive scans at one particular area is a basic concept. Repetitive scans at one particular area. And what this does is there are four basic principles of OCTA: speckle, volume, decorrelation, and emphase. What does that mean? Speckle is any effect produced by a scan that is interpreted. Decorrelation is the most important thing in OCTA, is a difference between two speckles. That is, when you have one reflected image and the second reflected image, the difference is called a decorrelation. And the volume and the emphase are the imaging methods. The volume is that the OCTA produces not a single, it's depth resolved. You have multiple layers in which you can interpret, and the emphase is the way of looking at the scan. In a regular OCT, it is sideways. The OCTA is always from the top. You're looking from the top like you do. And so these are the four basic tenets. So I just want to tell you that this is a basic principle. When you have two scans and something changes, the assumption, the only moving thing inside the eye is RBCs when everything else is kept. And that is tracing the path of the RBC is a de facto way of identifying blood vessels. So the principle is that when the RBC moves, the movement is detected, and you see the small red line that the movement is picked up. The problem is that if the RBC is too slow, there will be no difference between the speckle. The machine doesn't produce and you don't get, and this is called an interscan time. And if it's too fast, the same thing happens. Between the two speckles, in that threshold, nothing is caught. So this is a basic principle of OCTA. And the clinical applications, just we have to say that this is not dye-less angiography. That's the first thing we just have to get into. The whole new brilliant concepts of diagnosis. So today we'll either learn something truly revolutionary or we'll learn how to talk like a retinal surgeon. So the AMD diagnosis, the first important thing is how to capture the image. I'm not going to these things because we're talking about interpretation, but I just want to show you the same image based on the scan depth, the scan thickness. You can interpret a CNVM in different shapes and sizes, which means that when you want to reproduce something, you should know the original set or the original slab depth and all those things to know how big or how small a CNVM is. This is another example. Different slab sections, different area, the CNVM looks different in different sections. So when we go to AMD, I like to write it in the opposite way: type 1, type 2, type 3, and the yellow line is the RP. It's a very simple way of understanding where the type 1 is, where the type 2 is, and what is a type 3. And when we look at a lesion, these are the things we look at: caliber of the vessel, compactness, whether it's filamentous or not, the pattern of the vessel, the gaps between the vessel. We'll just go through these in detail later. So we'll first look at type 2. So if you look at a type 2, it's like you see in an FA. It's very compact, very lacy, lots of small vessels, hardly any gap between the vessels. It's a very compact lesion. And these are some more examples where you see in the structure flow, you see over here, you can see that there is a yellowish dots which indicate movement of the RBCs, which is above the RP line. So that's how you know it has breached the RP line. So as I said, this is how you make out a breach. If you look at this picture, you see a pattern above the RPE, which tells you that the RP has been breached by the vasculature, and therefore this is a type 2. Type 1 is below, type 2 is above. Again, here you can see that with the RP being represented, there is the flow characteristics are seen above the RP, therefore again this is a type 2. Just to show a few brilliant uses of the OCTA, you can see the structure of the vascular net much better than in any angiographic process where pooling and leakage obscure the margins. Here you see the blood vessel edges very careful. Just look at this patient where by knowledge we know that this is, it looks like a late phase indicating a CNVM on angiography, and that's the size of the angiography. But when you look at this particular picture, you understand that the size is not what you saw. It is a oriented lesion, a horizontal, even slanted lesion with three major components going on either sides, and you see the vasculature better. So in the type 2, the vessel caliber is thinner. It is a very dense lesion. The filamentous type vessels are uncommon. It has a lacy pattern. The gaps between the vessels are less. Perilesional halo, I'll come to that later, is less. The flow characteristics show breach, and the inability to image by obscuration is comparatively less because it's already come up above the RPE. So you image it better. So the type 1 lesions are very different from what we saw. You can see immediately from the picture, you can see that the fine nature, the fibrillary nature is lost. Fibrillary becomes filamentous. You see larger vessels, more defined, more gaps between the vessels. This is a very beautiful picture of a type 1. Large vessels going in different directions, gaps between the vessels, and the very fineness of the constitution is lost because it's of this. And just one word on perilesional. Perilesional is very important because it's a dark area around the lesion. Why does it happen? Because the CNVM is stealing from the choriocapillaris around it. So it doesn't image well around it. The choriocapillaris around it is dark. So again, I'm just skipping that, but let's look at this. The vessel caliber is thicker. The compactness is looser. There are gaps between it. It's a filamentous pattern. A perilesional halo is seen commonly. The flow characteristics show that it's under the RPE. Okay, the structure flow doesn't go above it, and there is often inability to observe it because there are hemorrhages, there's edema, there's fibrin, so all these things. So these are some of the morphological characteristics of AMD. You have a lacy pattern. Sometimes you get a medusa head where the feeder is in the center and goes to all sides. The C-fan is when the feeder is on one side and the vessel grows to the other side. And there's other components like the fishnet, which is extremely dense but has larger vessels. This is a worse prognosis type. The dark halo sign, as I said, is because the lesion steals from the choriocapillaris around the lesion. And you can see it over here. Here you see the lesion, but you see this dark rim going around it, and that is where the steal happens. So look at this picture. I like this picture. Just look at this picture. You can see two things. Inside is what a type 1 looks like, filamentous spaces. Outside is what the type 2 looks like. So if you keep this picture in your mind, you'll always try to correlate and understand what a type 1 and a type 2 looks like on an OCTA. So type 3, I am not going to spend time on type 3. Why? Because you see all these features you get on angiography, and this is what you get on OCTA. Sometimes you get a retinal spot because of the thing, but the characteristics are extremely hidden. For OCTA is not the ideal investigation for a type 3. Now let's go to PCV. PCV, we know how it looks. And when the OCTA came, it was slightly disappointing because the flow characteristics weren't perfect in OCTA. So I'll just show you. This is what a PCV looks like. The ICG would give much better. Here you can see a fibrillary network, which is a BVN, and a few dots on the center, which are polyps. This is a brilliant representation. You never usually get it this well. Why? Because usually PCV are associated with high PEDs, and whenever there is a tremendous disruption of when you get height in your PEDs, the imaging on OCTA goes bad. So these are an example. You can see here on this picture over here, you can see the BVN, and at the edges you can see nodular outpouchings. Again, if you look at the OCT, you know it's not very high, and that's why you're getting these imaging well. The minute it goes high, you don't get the proper segmentation lines. So these are all comparatively well things, and these are things. They're called divided into circles, the polyps, circles, clusters, spots, and undetected. Mostly it is, this is what we get. We don't detect it well. But the main thing is that OCTA is great to diagnose BVNs and bad to pick up polyps in PCV. So you get indirect evidence of a PCV on OCTA. Sometimes you don't get the direct evidence. And this is an example of it. So MACTEL is the next condition. So when the main use of MACTEL in MACTEL is to diagnose when a non-proliferative stage 1, 2, 3, 4 becomes stage 5. That is the main use of OCTA in MACTEL. And there are a lot of features, and let's go to the features. You have abnormality of the vessels in the temporal periphery, and then you have a vertical change where you see these abnormalities in different layers. You are not supposed to see any vasculature in the avascular layer, and and if you see this vasculature in the avascular layer, that's a CNVM. So it's very simple. It's a CNVM. Therefore, it has become proliferative. So just look at this picture. So let's look sequentially. The superficial vascular plexus, the intermediate vascular plexus, where you look at the temporal side over here and you see some vasculature, some change in flow, some abnormal dragging of the vessels. Then it becomes more in the DVP. But in the avascular zone, you don't see anything much, which means that this is a non-proliferative. And now let's go to the next one. The superior, the venous plexus, the intermediate, there's dragging changes. But in the avascular zone where you're not supposed to see anything, you see a lesion, a vascular lesion, which is a CNVM. And this is how you differentiate non-proliferative from proliferative MACTEL. Another use in MACTEL is that when there is a CNVM and you do an FFA, you get a lot of blooming. You don't know whether this blooming or leakage is because of the MACTEL or because of the CNVM. But look at this. The OCTA picks out this anatomical component of the CNVM and tells you that it has gone beyond a plain non-proliferative. It is not the blooming because of the it is the blooming and the leakage because of the CNVM. Okay. So just look at these features. Non-proliferative, you see all these features, and the proliferative, you see true flow in the avascular layer. So this is how you differentiate a non-proliferative and a proliferative, and all the features put together essentially. The other uses of in AMD are this condition. It is called a non-exudative CNVM. You see a bumpiness over there, which we also call the double layer sign, but no signs of CME or SRF. It's a CNVM which is not exuding. It's a new concept. Why? It's a precursor lesion. They convert 22% to 50% convert to in the next 24 months. So when you do an OCTA, this is an OCTA diagnosis. When you do an OCTA, you see a vascular net, but no ill effects of the vascular net. And you see it very clearly over here. And this is the thing. There are two types of non-exudative CNVMs. One is because of angiogenesis. They are subclinical. They're going to become a CNVM later. And the next is because of arteriogenesis. They are the truly quiescent ones that are sitting there, not causing any harm. They are quiescent non-exudative CNVMs. I'm not going to detail, but there are two types essentially. And in the picture you say one has a lacy pattern, it's not CNVM yet, and the other has a more filamentous pattern with gaps. So angiogenesis versus arteriogenesis in the very cellular level. This is a cellular tissue level differentiation. And why does this happen? It happens because of recapitulation. Why? A non-exudative CNVM or a CNVM after treatment that remains are actually beneficial to the RPE. They provide alternate nourishment, alternate circulation to prevent atrophy happening. So that is why in the newer and newer concepts lead us not to aggressively treat CNVMs till the last drop of SRF has gone away. You may observe or tolerate is the right word, a little bit of SRF. So these are, and this is the protective. There's no SRF, no CME, but you can see there's a large vascular net on OCTA exactly underneath the fovea at a large area, and that is the CNVM or the residue of the CNVM providing circulation to the RPE. It's a protective effect. So I will just probably stop with this. Recurrence of CNVMs. How do you know when a CNVM is coming back after treatment? It's a beautiful picture to show you. You see the edges, you see small anastomotic things going along the edge. You see small vessels in between the large filamentous vessels. And this is how OCTA tells you that a CNVM is recurring. You see this picture over here. You see the anastomotic channel in the edge, and you see it happening. So in this you see anastomotic. This is the older part of the CNVM which is quiet, and this is a newer part of the recurrence which is active nowadays. And this is how it happens. The last part of the talk, I'm limiting to AMD, is identifying scars. So in a scar, what we said about the fibrillary nature, dead tree, there's a tree with no branches. This is the appearance of that. And this tells you whatever we talked before, there are no small branches, there's no peripheral lesions, it's just like film, like a dead tree. And the second point is called skeletonization. When the CNVM breaks into small and it looks like bones of a hand, that is when you see the flow is fragmented in the CNVM, and that is a sign of regression of the CNVM or skeletonization. Okay, you can see it well in this picture. A fragmented vasculature. So again, when the thing is improving or it is down-regulating or going away, it becomes less compact, more filamentous, a dead tree pattern, gaps are more, and when it is up-regulating or recurring, it becomes more fibrillary, more compact, peripheral changes are more, the vascular density is more. Again, look at this as my parting slide, the same picture. Inside is how a regressing looks like, outside is how a progressing looks like. So with this picture, if you keep it in your mind, you can differentiate a type 1 and a type 2 and a regressing and a progressing. And I think I'm going to stop here. And this was the just an interpretation in AMD. Thank you.
Thank you, Unni. A fantastic talk as usual. I guess everybody picked up a lot of pearls on OCTA interpretation. So thank you very much, and hope to see you next.